So good morning, everyone. Before I start, I would like to thank, on behalf of the Clinical Infectious Diseases Society of India and the Transplant ID Subcommittee, I would like to thank ISOT and the organizing team for, having this day on Transplant ID, and CMC Vellore, who has done a lot of work behind this. So Dr. Priscilla and Dr. Subramaniam Swaminathan, who have been instrumental in taking this Transplant ID Subcommittee forward along with Sunita ma'am. So again, thank you for giving us this opportunity. And every year we have one full day on behalf of the ID Society as a part of ISOT, wherein the idea is, that we have an exchange between the surgeons, transplanters, and the ID people. So it's been that now for a fairly long time and has been running very successfully. So once again, thank you for having us. And with that brief introduction, I think I'll start with my first talk. Okay, so I'm going to be talking about C. diff in the setting of solid organ transplantation. Now, we all know that C. diff is a big problem, not just in the SOT patients, but also in our immunocompromised patients and increasingly in a lot of the other hospital patients as well. In fact, there are concerns with community-acquired C. diff as well. So let's pause for a moment and look into how someone gets C. diff. So if you have a patient who is colonized with C. diff, so someone who has been exposed to the hospital environment and has now been colonized with C. diff, there are certain factors which will determine whether this patient remains an asymptomatic, someone who has asymptomatic colonization versus someone who has true C. diff infection. And these are these factors are things like bacteriocin secretion. So the good bacteria in the microbiome usually secrete bacteriocin. The composition of bile acids, how intact the humoral immunity is, that will be an important factor. What are the acid levels of the stomach, because acid can bother C. diff. So all these factors work in the favor, which means that they will keep the asymptomatic colonization asymptomatic. They won't let the C. diff progress into active C. diff infection. Now, we'll see that our transplant patients have a lot of these factors going against them. So, for example, getting PPIs, which is going to reduce the acidity of the stomach, getting antibiotics, which is going to thin out the microbiome, so you're going to lose the good bacteria. Again, post-transplant hypogammaglobulinemias, which is going to affect the humoral immunity. So a lot of these factors affect the transplant patients. So not surprisingly, there are a lot of risk factors as far as C. diff is concerned in solid organ transplant recipients. Some of them are because of the fact that they have a lot of healthcare exposures. Some of them are unique to the setting of solid organ transplantation. So, not surprisingly, all of them have healthcare exposures. These are patients who have been on dialysis pre-transplant or who have had admissions for worsening of their chronic liver disease. They have received a lot of antibiotics even in the post and perioperative period. So, there are a lot of stewardship opportunities on the way as well. Many of them receive proton pump inhibitors. Like I said, if the PPIs reduce the acidity, then it can be a problem. Surgery itself, then immune suppression, so induction with ATG. This has been shown to increase the risk of C. diff. And then there are certain unique risk factors as well. So for example, high MELD scores in the setting of liver transplant or prior VRE colonization in renal transplant. And like I said, humoral immunity is an important defense. So severe hypogammaglobulinemia, in studies it has been shown more so in heart transplant recipients, but in general hypogammaglobulinemia can be an important risk factor. So not surprisingly, the risk will be the highest during the first 3 months after transplantation, because that is the time patients are going to get induction immune suppression, they are going to be put on perioperative antibiotics, the effect of surgery. So all these things will mean that in the first 3 months, the risk will be the highest. Going forward, there are two things which will determine their risk. How often do they get antibiotics and how often do they get treated for episodes of rejection? These two things really determine their long-term risk, and that is why these are again stewardship opportunities. For example, late asymptomatic bacteria in the renal transplant patient. We'll have a session on that later in the day. So, these are good stewardship opportunities in this setting, because late onset C. diff is usually associated with either getting antibiotics or being treated for episodes of rejection. So this is what the microbiome does through a renal transplant. So it is very important to understand the changes that the microbiome undergoes during the process of transplantation. And here you have a diversity index known as the Shannon's diversity index, and that is a standard measure used to look at the microbiome. So which means that you want your microbiome to be as diverse as possible. You want it to have good organisms, you want it to have a lot of diversity. And you can see in this study here that compared to healthy controls, renal transplant recipients do have lower indices, which means that the microbiome or the microbiome diversity is lower in these patients compared to healthy controls. And in this study, use of MMF and the use of antibiotics not surprising, but the use of MMF as well, negatively correlated to the Shannon's diversity index. So that is an important finding. Look at liver transplant patients as well. I have included studies only from the liver and kidney populations. So look at liver transplant patients, first 3 weeks post-transplant, the diversity is again going to go down. There are also studies which look at the microbiome composition during this period. So not only do you want your microbiome to be diverse, you also want it to be comprised of good organisms. So if the intestinal domination or the microbiome domination shifts from the bad bacteria to, from the good bacteria to the bad bacteria, then again it's a problem. So a lot of times in transplant patients, in the peri-transplant period, the domination will shift from good bacteria to pathogenic bacteria like E. coli, and that can be a problem. So this study shows that in the first 3 weeks, the microbiome again thinned out. So that's why, not surprisingly, the burden of C. diff in the world of solid organ transplants is fairly high. Now on the right, I have put numbers in the bone marrow transplant patients. So it's not as high as in the HSCT recipients, but it is still considerably more than what you would see in your other hospitalized patients or especially immunocompetent patients. And again, in this meta-analysis, multi-organ transplants had the highest rates, followed by lung transplants. Traditionally, renal transplant recipients don't have very high rates when it comes to C. diff. Not just the incidence, but the mortality is considerable as well. So you can see this large study here, more than 100,000 patients. The incidence was about 3%, but C. diff was associated with a higher inpatient mortality. So what are the clinical manifestations of C. diff, especially in our solid organ transplant recipients? So we say that watery diarrhea, more than 3 bowel movements per day, you should be suspecting C. diff. Now in our transplant recipients, there are lots of differentials beyond C. diff for this. Many of these differentials can be non-infectious differentials. So both infectious and non-infectious differentials are important when it comes to watery diarrhea in this type of a population. Usually leukocytosis can be seen in C. diff, but that's more so in the non-transplant patients. Both in our BMT as well as SOT recipients, we can actually see leukopenia, and that can be a problem. So that's why traditional scoring systems which use leukocytosis or low albumin, they may not be perfectly applicable to our solid organ transplant recipients. Usually C. diff is a colitis, it's not an enteritis. So you will rarely see bloody diarrhea, so melena or hematochezia will be rare. And there could be very rare extraintestinal manifestations. What we need to look out for is this syndrome known as fulminant colitis. And again, literature shows that up to 15% of our solid organ transplant recipients who have C. diff can actually have fulminant colitis. So that's significant. So fulminant colitis is when you have signs of hypotension or hypoperfusion, so septic shock, increased lactates. And the important point here is that we should be able to pick these patients in the pre-fulminant period, because that's where you will want to add another IV drug and so on. There are studies which show that C. diff is associated with biopsy-proven acute rejection. And that is interesting. I mean, the factors are not very clear, but it has been associated with biopsy-proven acute rejection. When you look into studies of tacrolimus levels in patients who have C. diff, the levels are not very different, because one would think that is it because of the fact that they are not absorbing the immunosuppressive medications properly that this is leading to rejection episodes. Now remember, C. diff is a colitis. It is very rarely an enteritis. So usually it is not something which is associated with reduced levels of immune suppression. So the immune suppression absorption is not a major issue here, but yet there are studies which show that these patients could be at an increased risk of biopsy-proven acute rejection. Like I said, there are scoring systems which look at severe C. diff versus mild to moderate C. diff. But there are two things here. One is that these scoring systems now are not used very regularly in the treatment, wherein mild, moderate and severe, we are treating almost the same way. It's only the fulminant wherein we are usually adding the IV drugs on top of something like an oral vancomycin. So that's the practicality of it. And the other thing is that some of these points or some of these aspects based on which these scoring systems have been formulated, they may not be applicable to our transplant patients. So for example, like I said, these patients may not always have leukocytosis. There are studies which show that they may have leukopenia. They may not always have evidence of pseudomembranous colitis. I'll show you a study on that. And they may have reduced albumin levels because of other reasons. So look at this study here, 8 immunocompromised patients, all with C. diff, none of them actually had evidence of pseudomembrane formation. So that's why our immunocompromised patients may not always have pseudomembranous colitis. So let us look at this patient, a 43-year-old male, 3 months post living donor renal transplant, presents with diarrhea for 4 days. Now, as we all know, there are lots of differentials here, infectious as well as non-infectious related to immune suppression. Within the infections, there are viral etiologies, there are bacterial etiologies. So the patient is on MMF, tacrolimus and steroids. His C. diff GDH antigen is positive, but toxin is negative. So how do we go about this kind of a situation? Now, there are several ways in which we can diagnose C. diff. Most labs will use a two-step algorithm. So in the first step, they'll either do a GDH antigen. More commonly, some labs may want to start with a PCR test, but more commonly the labs will do a GDH antigen in the first step. Now the GDH antigen is sensitive, but GDH positive does not mean infection. It could be just colonization with C. diff. Whereas the toxin assays, they are less sensitive, but if the toxin is being produced, then definitely you are more worried about this being an actual C. difficile diarrhea. So when it comes to PCRs, one very important thing to remember is that these PCRs detect toxigenic strains. So they don't actually detect toxin production. They detect the genes that are involved in toxin production. So that's why they detect these TCD-A and TCD-B genes. So PCR being positive doesn't always mean again that there is infection. PCR negative, you can be fairly certain that C. diff is not there. So remember that PCR detects genes for toxigenic strains or genes for toxin production. It's not the actual toxin that is being detected. And cultures and neutralization assays, although would be good to have, they are tedious and requires a high amount of expertise. So they are not readily available in clinical practice at all. So this can be a good table to follow. So if you start with the GDH antigen, if both GDH antigen and toxins are positive, then there is no doubt that this patient has C. diff. And you need not have both the toxins positive, either one could be okay. So as long as you have GDH positive and at least one toxin positive, this is CDI. If you have both negative, which means GDH is negative and both toxins are negative, there is no doubt that this patient does not have C. diff. The gray zone, like I put it on the chart here, is if someone has a GDH which is positive and toxins which are negative. So here the pre-test probability is very, very important, and that's why we should selectively send C. diff testing, especially in our transplant recipients, because like I said, there are lots of other reasons why these patients could have diarrhea. Also, a large number of these patients could be colonized with C. diff, which can give GDH positive. So that's why we need to select out patients, we need to have a good pre-test probability. In this setting, a PCR can be useful, but how? Only if it is negative can we rule out C. diff. If a PCR is positive, it could still mean being colonized with a toxigenic strain, because like I said, a PCR does not really detect the toxin itself, it detects the genes for toxin production. So PCR being negative can help in ruling out C. diff, but a positive PCR again will lead you to the same dilemma that clinically is it C. diff. And if you start with PCRs, then again both negative not a problem, both positive not a problem. PCR positive and toxin negative, you go back to the pre-test probability, that does this patient really have C. diff? So that means ruling out other etiologies, looking at the clinical picture, and ruling out other etiologies, as you all know better than me, is easier said than done in our transplant patients. There are certain other caveats that it should not be used as a test of cure. It should not be repeated within the first 7 days unless the diarrhea is really worsening, and so on. Now, in solid organ transplant recipients, the sensitivity of the toxin assays might be lower than in the immunocompetent patients. So here again, this study shows that patients who are on high-dose steroids, immunocompromised patients, they can have lower sensitivity for the toxins. So with that, let us go to the treatment of C. diff associated diarrhea in our settings, and I will also be spending a lot of time talking about FMT in this setting. So if you look at the initial episode, then there are 2 drugs which are globally recommended. One is fidaxomicin, narrow spectrum, sidle, but not available readily in India. So that is the problem. Otherwise, it's recommended for the initial episode. The other option, of course, what we use is oral vancomycin. Now, if you look at comparative studies, there is not much of a difference between the outcomes, but there is some difference in the recurrence rates when it comes to fidaxomicin versus oral vancomycin. If unavailable, then only the guidelines recommend using metronidazole. So metronidazole has now been placed lower. The other problem, of course, is metronidazole in our patients, in the SOT patients, can interact with the immunosuppressive drugs that these patients are on. So again, for the most part in our settings, we will be using oral vancomycin. We don't have the 125 milligram preparation in India. So for most of our patients, we'll be starting with a dose of 250 milligrams every 6 hours. There is increasing literature about C. diff being resistant to vancomycin. So there are increasing number of cases of vancomycin refractory C. diff being described. These are different studies that I have compiled from all over the world. The one on the left compared isolates in the US and isolates in Africa. And on the right also you can see that studies from Europe, South America, Israel, they all have shown considerable amount of resistance or a significant percentage of these isolates being resistant to oral vancomycin. So there are studies now which have looked into oral teicoplanin as an option for treating C. diff. And this is one of the biggest on them. You can see here that patients who got oral teicoplanin, the clinical cure was actually slightly higher. So although it wasn't statistically different, oral teicoplanin can be a good option. So in our settings, if the patient is refractory to oral vancomycin, and how do we decide that? By around day 4, if there is not more than 50% reduction in these stool volumes, then you start suspecting refractory C. diff. If that is the case, then we have been using quite a bit of oral teicoplanin. This is something that we have just submitted for publication. So this is the experience about BMT recipients, and this is the first year after C. diff, but look at these numbers. The patients in whom oral vancomycin was used, 27% were refractory. So almost a third of our patients, or a little more than a quarter of the patients, were refractory to oral vancomycin. When they started with oral teicoplanin upfront, the refractory percentage was around 13%. So in our settings, when someone is refractory to oral vancomycin, we do switch over to oral teicoplanin. For severe C. diff, the recommendations are not very different, like I said, and also again going to the fact that severity scoring systems may not be perfectly applicable to our solid organ transplant recipients. The only thing is that if the patients are unable to tolerate oral vancomycin, then you can give it by a nasogastric tube. Coming to the category of pre-fulminant and fulminant, this is the category which is clinically important to recognize, because this is a patient now who is starting to show signs of hypoperfusion. So what do the guidelines recommend? Oral vancomycin, high dose, plus an IV agent. So an IV agent like metronidazole and tigecycline. Both are not easy to use in the setting of our transplant patients. Metronidazole, like I said, has interactions with the immunosuppressive drugs. So it's a CYP inhibitor. So you'll have to monitor these drugs carefully. Although one might argue that in the setting of diarrhea, are we really having enough levels of the immunosuppressive drugs? But like I said, C. diff is primarily a colitis, it's not an enteritis. So there's not much reason for our patients to really have subtherapeutic levels of the immunosuppressive medications. And the other drug is IV tigecycline. So again, easier said than done, especially in the setting of liver transplants, though personally, we have used quite a bit of IV tigecycline in our liver transplant recipients as well. And the result has been fairly okay as far as safety is concerned. So these are two options. Efficacy wise, tigecycline has a decent amount of data, especially being generated in the last 2 or 3 years. But it is an option that I would use only for the fulminant cases, not an option that should be used, let's say, for a mild, moderate episode upfront. So especially for the fulminant cases, this can be a good option. Going to recurrence, what do you do when someone has recurrence? So you have 2 or 3 options there. The first recurrence, again, we don't have fidaxomicin, so could be a long tapered and pulsed regimen of oral vancomycin. Subsequent recurrences also, either you could do a long tapered pulsed regimen, or the other option is doing an FMT, and that's where the role of FMT comes in. So right now, when should you consider FMT? So right now the recommendations say that the best indication for an FMT is when the patient has had many recurrences. You can argue that in the first or the second recurrence itself, you can start thinking about FMTs, or patients who have fulminant refractory C. diff. Now, that setting in India is much easier said than done, because we don't have stool banks, we don't have preformed stool capsules. So I can't do an FMT the next day when I think of it. It takes at least 3 to 5 days for the donor screening, for the solution to be prepared, for the counseling and all the end process to do FMTs in India. So rescue FMT in the setting of fulminant C. diff is much more difficult to perform in our settings. So coming to the data on FMT in the setting of solid organ transplant. So this is perhaps the largest study which looked at 94 SOT recipients, SOT patients who underwent FMT. 78% for recurrent C. diff, whereas 22% for severe or fulminant C. diff. Like I said, more difficult to perform in our settings. In our settings, FMT for recurrence is much more doable, as I'll show you my own experience at the end. Severe AEs occurred in 3% of the cases. The good news was that there was no FMT related bacteremia, because there have been some concerns about FMT related bacteremias in immunocompromised patients. At 3 months, the primary cure rate was around 58%, whereas the overall cure was 91%. So what does that mean? That some patients required either a second FMT or subsequent antimicrobial therapy for C. diff. And most of the times, if you look at the literature in immunocompromised patients, even outside SOT, if you look at the BMT literature or if you look at oncology literature, the findings are similar, that most patients will require a second installation of FMT. And when you do that, when you do about 2 installations, the cure rates are much, much better. So in this study, safety-wise, there were no major red flags. What I found a little concerning was that 3 patients had CMV reactivations. Now, even in our experience, we have had patients who have had CMV reactivations after FMT, and that has been a slight cause of concern. So I'll come to the donor screening part in a minute. The good part is that neither C. diff nor FMT has been really shown to influence the or tacrolimus levels to a great extent. So you can see from this here that the concentration dose ratio of tacrolimus really remained similar through the process of FMT. These are the screening criteria that we use in our center. So as far as lab evaluation is concerned, so screening the donor is a challenge in our setting. So we have to screen multiple donors to get to the right kind of donor. And laboratory wise, what is mandatory is screening for syphilis, hepatitis and HIV. Now the 2 things that are interesting is that should you be screening donors for CMV and EBV? So blood test for CMV and EBV when you're trying to do an FMT in the setting of solid organ transplants. Now what we know is that the CMV seroprevalence is very, very high. It can be close to 100%. In fact, very rarely do we see anyone who has CMV IgG which is negative in our settings. The frequency of stool shedding as far as these viruses are concerned is, the data is limited. And are there known cases of FMT derived infection? The answer is we don't know, but it is possible, because even in this study there were 3 patients who had FMT reactivations. Now again, a reactivation is very different from, let's say, fecal transmission of CMV. So there could be immunological factors there at play, but there has been some concern about CMV reactivations. So what do the consensus statements recommend? So one that was published in 2019, what they say is that if you have a donor who is IgG positive and a recipient who is IgG negative, and by donor I don't mean the transplant donor, I mean the FMT donor. So if the FMT donor is IgG positive and the recipient is IgG negative, which happens very, very rarely in our settings, then you should have a conversation about the potential risks with the recipient. But you shouldn't exclude the donor just because he is CMV IgG positive. If he is CMV IgM positive, that's a good enough reason to exclude the donor when you're trying to do an FMT. The first situation, like I said, we don't land into very often, because hardly any of our patients, especially in the post-transplant period, will be CMV IgG negative. So this is the, sort of the technical preparation that goes behind it. So at least 50 grams of stools are taken, they are processed in a biosafety cabinet. Then our microbiology department does all this, and then within 6 hours of the donor voiding, we actually have to make sure that the preparation goes inside the recipient. So there are some logistic issues, there are some technical challenges. I remember one of the donors that we had used to pass stools only at midnight. So of course the microbiology department said that we are not going to come at 1 in the morning to prepare an FMT solution for this kind of a recipient. So there are some procedural caveats in India. So it can either be administered via lower GI tract or upper GI tract. Generally the data is comparable, but lower GI has been found to be slightly more effective. Now stool banks and stool capsules are something that we lack. So that's why, from the time I start thinking of an FMT to actually administering the preparation, it takes at least 3 to 5 days for all the workup that I talked to you about. In our BMT patients, this was the initial experience that we published in our BMT recipients. Since then, we have done about 20 more. But in our BMT recipients, we had to screen a median of 3 donors to get to the right kind of donors. A lot of times, we'll have to screen for 4 or 5 donors. So we've had donors who have themselves had GDH antigen positive. We've had donors who have been found to be colonized with carbapenem-resistant E. coli. So all sorts of things can happen in our setting. So that's why donor screening has to be very, very rigorous. And in the first 13 patients that we did, one had bacteremia, one had candidemia, and one had CMV viremia. So there are larger studies which need to be done as far as safety is concerned. But in general, like I said, these safety issues over the last 2 or 3 years in immunocompromised patients have not been found to be very different from the immunocompetent patients. CMV is still something that is debatable. So I'll summarize by saying that C. diff infection is an important problem in the setting of SOT. The burden is definitely more than immunocompetent patients, slightly less than the BMT patients. A 2-step approach to diagnosis is recommended, so wherein we start with the GDH antigen and then look at toxin production. For discrepant results, which means GDH is positive, but the toxins are negative, we can consider a PCR. But remember, a PCR positive doesn't establish C. diff. PCR negative rules it out because it tells you that the patient does not have a toxigenic strain, whereas a positive still can lead to the conclusion of being colonized with a toxigenic strain. Management can be challenging, so there are constraints. We don't have access to fidaxomicin. FMT as a modality is emerging in transplant recipients, so far the studies all over the world show that it is fairly effective, provided you do more than 1 rounds of FMT, and it is fairly safe. The safety concerns are not very different from the immunocompetent patients. Testing for viruses is something that still doesn't have a lot of data, but right now can be considered. And in India, it is doable, like I said, but it does have its own constraints, and careful donor selection is very, very important. So I think with that, I'll stop. Thank you once again for the invitation, and I look forward to the rest of the day.